I would like to start this chapter with an example which should show you that aortic aneurysms don't necessarily have to look the way we expect them to look. I would like to start this presentation on the aorta with a case. The case of a 74-year-old male who presented with pericardial effusion, pleural effusion, and also fever. To exclude endocarditis, we performed a TE study, but we did not find a vegetation on the aortic or on the mitral valve, but what we found was a cavity located here adjacent to the aorta, right next to a plaque, an atherosclerotic plaque of the aorta. You can see the fairly large cavity right here, and with the help of color Doppler, it was also apparent that there is flow within this cavity. If you look closely, you can actually see that there's a communication between the aorta and also this cavity. To further confirm this, we also performed a contrast study with a contrast agent which opacifies the left heart. And here you can see that there is flow from the ascending aorta into this cavity. The cavity slowly started to opacify. So this documented that this must be some form of pseudoaneurysm of the ascending aorta. To further confirm this finding, we also performed a CT. And here you can see the cavity, the pseudoaneurysm, right adjacent to the ascending aorta. Now this is obviously a life-threatening condition, as many aortic pathologies. In this case, we were not able to operate the patient anymore. He died only hours later. The normal wall of the aorta is quite thin. It only measures 4 millimeters. And we can subdivide the layers of the aorta into the adventitia, the media, and the intima. We can subdivide the aorta into different sections: the ascending aorta, the aortic arch, the descending aorta, and everything that is below the diaphragm is actually the abdominal aorta. When you go into the literature, it's quite difficult to really find normal values for the width of the aorta. But these are values that we use. The ascending aorta between 2.5 and 3.5 centimeters, the descending aorta between 2 and 3 centimeters, and the abdominal aorta between 1.8 to 2.8 centimeters. You can see here that the aorta gets slimmer the further down we get. So the size of the aorta does not only depend on where you measure, but also on other factors, such as sex, age, body surface area, and also on the initial diameter. Usually there is an increase in the diameter of the aorta of 1 millimeters per decade. And here are the normal values for the aorta related to body surface area. The ascending aorta 2.1 centimeters per square meter, the descending aorta 1.6, and the abdominal aorta should be below 3 centimeters. Now let me turn to aortic pathologies. It's very important to understand that there's a very close relationship between the different forms of aortic pathologies, such as aneurysms, aortic syndromes, which are composed of dissection, intramural hematoma, and penetrating ulcer. We'll talk about all these later. Congenital defects, or connective tissue defects. This also includes patients who have coarctation or bicuspid valves, and that all these, again, are closely related to atherosclerosis and other risk factors. For example, if you have atheromas and atherosclerosis, this predisposes to aneurysms, but also to aortic syndromes. The same is also true for patients who have connective tissue disorders. They also have a higher likelihood to develop aneurysms and dissection. First, I would like to discuss aneurysms. By definition, an aneurysm is characterized by a localized dilatation of more than 50% compared to a reference segment. The problem in reality is that the reference segment is often also dilated. And you have to be aware that we have circumscript or diffuse aneurysms. Here is a more diffuse form, and here is a more circumscript form. In contrast, a pseudoaneurysm is defined as lumen expansion due to perforation, which involves all layers of the aorta. This is in contrast to a true aneurysm, where the wall is actually intact. Remember, at the beginning of this chapter, I showed you a patient who had such a pseudoaneurysm. And remember, there was a small cavity that formed. This was a pseudoaneurysm. Aneurysms can be present in all portions of the aorta: in the ascending aorta, the aortic arch, the descending aorta, either above or below the diaphragma. And very often we see a combination of aneurysms. For example, an ascending aortic aneurysm which extends into the aortic arch. To help us better define where the aneurysm is and what the extent is, we have the so-called Crawford classification for the descending aorta. Here is a normal aorta. Type 1 would be an aneurysm from the left subclavian artery to the renal artery or the superior mesenteric artery. Crawford, type 2, would then be from the left subclavian artery all the way down to the aortic bifurcation. Crawford, type 3, would be from the 6th intercostal space, so below the subclavian artery, to the aortic bifurcation, so further down. Crawford, type 4, would be from the 12th intercostal space below the diaphragm to the aortic bifurcation. And finally, Crawford, type 5, is from the 6th intercostal space above the superior mesenteric renal arteries. And here is an overview slide which shows you all the different types of aneurysms of the descending aorta according to the Crawford classification. Now keep in mind, even though descending aortic aneurysms are maybe not such a domain of transthoracic echocardiography, we are able to visualize the descending aorta as well. Furthermore, with the help of transesophageal echocardiography, we do see these aneurysms, at least those which are located above the diaphragm. The classification of aneurysms of the ascending aorta is much simpler. We only subdivide them into the aortic root aneurysm, which involves the sinuses, aneurysms which are located in the ascending part, and such that involve the aortic arch. Keep in mind, however, that we can have a combination, more than one segment, or even all segments of the ascending aorta can be involved, and that sometimes we even have a combination of aneurysms of the ascending and the descending aorta. What is the distribution of aneurysms? Well, half of the aneurysms are located in the ascending aorta, 11% in the aortic arch, and 38% in the descending aorta. To highlight the importance of aneurysms and to put everything into perspective, here are some facts. Thoracic aortic aneurysms and thoracic abdominal aortic aneurysms are less common than infrarenal aneurysms. Death from an aneurysm occurs in 0.7 per 100,000 patient years, and death from dissection in 1.5. So you can see the big threat is rupture and dissection. Males and females are equally affected, and if you have an aneurysm with a dissection, you have a very high likelihood that you will not make it to the hospital alive. Aortic rupture occurs in 74% of all thoracic aortic aneurysms, with a high mortality rate of 94.3%. So once rupture has occurred, you actually do not have a chance. What is the pathophysiology behind the development of aneurysms? Well, it is very closely linked to a number of risk factors, to hypertension, hyperlipidemia, diabetes, and smoking. This leads to a number of changes which involve the wall of the aorta, such as intubal thickening, plaque formation, ulceration. It increases the vessel stiffness, and also it can lead to thrombus formation. The law of Laplace helps us to understand the physics behind the development of aneurysms. The wall stress, which basically is the trigger for the development of an aneurysm, is closely related to the pressure, the radius, and the wall thickness. The pressure would be the blood pressure. The radius, the degree of dilatation of the aorta. And a thin and weak wall also elevates wall stress. So you can see, if you already have an aneurysm, this predisposes to further dilatation of the aorta. But other factors, such as the strength of the aortic wall and the composition, also play a role. And it is now well known that patients who have bicuspid aortic valves, that they don't have a normal composition. Their wall is weaker. It is a fact that these patients have larger diameters of the ascending aorta, that 6 to 10% of all dissections occur in the setting of a bicuspid valve, and that patients with a bicuspid valve have a 9 times higher risk for the development of dissection. This diagram, taken from a publication, shows you that patients with a bicuspid valve have an abnormal composition of the aortic valve in all segments of the ascending aorta, in the region of the sinuses, the ST junction, and the proximal aorta. Bicuspid aortic valves are not the only entity which can lead to an abnormal composition of the aortic wall and to dilatation. There are a number of inherited disorders which affect the connective tissue, such as the Marfan disease, Ehlers-Danlos, especially the vascular type, the type 4. Then there are familial forms of connective tissue disorders and the so-called annulo-aortic ectasia. Only recently have we learned that there are numerous different variants of connective tissue disorders and that some cannot really be classified. They are so-called overlap syndromes. The most well-known form of connective tissue disorder which causes aneurysms and dissection is the so-called Marfan syndrome. It is characterized by an FBN1 gene mutation or an MFS2 gene mutation. You can also establish the diagnosis with the help of the so-called Ghent criteria. And remember, very often you don't have the classical type of Marfan syndrome, but more borderline manifestations in form of overlap syndromes. Here's a list of the so-called Ghent criteria, but it's probably better if you look them up in your fact sheets. The Marfan syndrome is present in 1 of 5,000 individuals, and it is the cause of dissection in 6 to 9%. The typical echocardiographic feature is that of a large aortic root and very large aortic valves. Here you can see the valve is tricuspid, but the entire root and also the leaflets of the aortic valve are very large. The typical cardiac manifestations of Marfan syndrome are, as we already discussed, aortic dilatation, aortic dissection, and aortic regurgitation, which is usually a result of aortic dilatation. Furthermore, we very frequently also note a mitral valve prolapse and a dilatation of the pulmonary artery. As a side note, one of the most prominent figures who had a Marfan syndrome was Abraham Lincoln. Another well-established form of collagen disorder which can lead to aortic dilatation and dissection is the so-called Ehlers-Danlos syndrome. It is characterized by hyperreflexible joints, hyperreflexible skin, typical facial characteristics which include very large eyes, thin nose, lobeless ears, and thin scalp hair, and also vascular involvement. Dilatation of the aorta usually occurs in the vascular type, which is the type 4, which is an autosomal inherited disease which involves a mutation of the COL3A1 gene, which encodes for type 3 procollagen.
So what is the key message here? If you have a patient who is young and who does not have any other risk factors for an aneurysm or for dilatation, then he should be or she should be examined much more closely. Maybe there is some form of inherited disease.
Other diseases which can lead to weakening of the aortic wall and thereby aneurysm formation is syphilis, Staphylococcal aureus, Kawasaki disease, and giant cell arteritis. So all diseases which involve some form of inflammation. But what in general are the complications of aneurysms? We already mentioned dissection and rupture, but other things can also occur, such as a shunt formation, for example with chambers of the heart, the right ventricle, thromboembolism, which is very frequent actually in the setting of dissection as well, and also in the setting of patients who have abdominal aneurysms. In addition, aneurysms can cause compression, for example the vena cava superior, but also compression of nerves, such as the phrenicus, the vagus, and the recurrent laryngeal nerve. Remember, we said that the diameter of the aorta plays an important role as to how quickly further dilatation of the aorta occurs. But not only that, the diameter is also important for the risk of rupture. And we know that if the aortic diameter is above 6 cm, the ascending aorta has a 30% chance of rupture and the descending aorta of 40%. And since the size of the aorta strongly depends on the body surface area, it's better to use this risk stratification scheme which indexes the size of the aorta to the body surface area. You have a low risk if the index is below 2.75 with only a risk of 4% rupture per year, a moderate risk if the value lies between 2.75 and 4.25, and a high risk if the value is above 4.25. In this case, you have a risk of 20% rupture per year. The natural history of thoracic aortic aneurysms is a survival rate of 24% at 2 years. The risk of rupture was also used to define guidelines for the indication of surgery for patients with aortic aneurysms. For the ascending aorta, it is the presence of symptoms, which however is a fairly infrequent finding. Aneurysms can cause local compression, but in general they do not have symptoms, only if dissection occurs, and then they have to be operated anyway. Another reason to operate would be if patients have a diameter between 50 to 60 millimeters. In other words, an index of above 2.75 centimeters per square meter. We should operate earlier in patients who have Marfan syndrome simply because they have a higher risk for dissection. If the growth of the aneurysm is accelerated, in other words, if it's above 10 millimeters per year, and if significant aortic regurgitation is present. And furthermore, if patients have to undergo operation for aortic valve replacement, for example, then we should also operate a diameter which is above 45 millimeters. Once the indication for operation is made, there are certain treatment strategies that you have to think of. With the ascending aorta, usually patients have to undergo surgery. For the aortic arch, we can combine it with stent graft implantation, for example, and a lot of aneurysms of the descending aorta are nowadays not operated but intervened with the help of endovascular stents. Here are some images which show you what type of stents are used. The classic type of stent, a stent which even has a bifurcation, and a stent which can be used in the aortic arch.
In reality, the decision whether or not to operate or to intervene is always a very difficult decision. Very often, you deal with very old patients and patients who have a lot of comorbidities. To make the decision, I think it's best to use an interdisciplinary approach to also involve the surgeons and the interventional radiologists. But now it's time to move on. We haven't yet discussed a very important piece of the puzzle, a piece which also relates very closely to aneurysms. It is the issue of dissection.